Hi, I'm Rona Mann.
And I'm Nicole House.
And our presentation is on pressure ulcer prevention. 2.5 million patients develop pressure injuries every year. The most common causes of pressure injuries are lack of mobility, moisture, and poor nutrition. Pressure injuries cost the U.S. health system $9 to $11 billion per year, making it the second most common hospital billing claim. Pressure injuries prevalence is increasing, therefore, relative to research is conducted.
As we all know, our skin is the largest organ in the human body. It's our first line of defense and it protects our internal organs from diseases. Protection to prevent from diseases is very important. So, protection against pressure ulcers is to assess skin integrity, provide adequate nutrition, assess activities of daily living, and patient mobility. Prevention also includes nursing education and patient knowledge.
Pressure ulcers are also known as pressure injury or bed sores. They're caused by persistent external pressure against the skin. And the most common areas for bed sores or pressure ulcers include the ischial tuberosity, the greater trochanter, the sacrum, and heel. Pressure ulcers cause unnecessary pain for patients. Patients develop disturbed body images, and the lengthy and costly hospital stays are increasing. Patients are at high risk for infection, and the risk assessment tool to prevent pressure ulcers are using the Braden scale method.
The methods that we used started out at the Rutgers Library System. SINHA, EBSCO, and PubMed were our primary research study sites. The search terms that we used were pressure ulcer prevention nursing and qualitative, and pressure ulcer presentation nursing and qualitative for research articles. Study 1 was a qualitative concept analysis. It evaluated multifaceted, unit-tailored intervention, and it used evidence-based practice. The participants were a focused group of nurses and first-line managers. It was a 3-part study with an introduction where the participants were introduced to the study and they were going through the mechanisms of the study. There was a 1-day training program and then followed by repeated quality measurements. The comparison of the before and after PIP intervention training, there was additional structured, was like an additional structured part of the concept. So basically these first line managers and these focus group nurses had their introduction, and then they went through a training of pressure ulcer prevention, a course, and then then they wanted to see and assess if this additional training worked. So afterwards, they wanted to see the attitudes of the nurses and the first line managers towards the pressure ulcer prevention, because positive attitudes would provide positive implementation of the protocol for intervention. The strengths for the study was that there were very positive interventions, and they were very consistent on their interviews. The weaknesses is that there was a limited number of participants due to availability, and the availability was because a lot of the nurses did not work the shifts that the researchers were available, so they had to limit it to volunteers and people that were working those particular shifts. Study number 2.
According to the National Pressure Ulcer Advisory Panel, the prevalence of pressure ulcers ranges from 3 and 14% among acute patients. Elderly patients with pressure ulcers have communication barriers, or they also have limited cognition. It is useful to find a pain assessment instrument with high validity and reliability. Therefore, the FACES rating scale was used in clinical settings and describing the mathematical relationship between the visual analog scale and the FRS when they are used to quantify pressure ulcer pain in elderly patients. To continue, instruments used in this study was a 0 to 100 millimeter horizontal line to have ratio scale properties with high validity and reproducibility used by the VAS. The FRS used 6 spaces horizontally from smiling to crying, labeled 0 to 5 beneath each face. The method used was a nonlinear least squares regression with a Gauss-Newton iterative procedure. As a result, the nonlinear relationship indicated high reliability between the VAS and the FRS for pain assessment in populations with diminished verbal and abstract thinking abilities. The FRS is best measured in assessing pain before and after wound care, especially those who have difficulty verbalizing their pain. For study number 3, the nursing role effective model was used for investigating the relationship between evidence-based practice and client outcomes. A cross-sectional design was used to test the hypotheses. Over a 9-month period, data on nursing interventions and client outcomes were collected through a chart audit. The data was collected on EBP nursing interventions and documented in the client records. Visiting nurses documented pain frequency, dyspnea, falls, and pressure ulcer outcomes on admission and then on discharge or after 4 months. Pressure ulcers were staged from 0, no pressure ulcer, to 5, necrotic eschar predominant. This was a quotation I had from my studies of my research. Out of 76 cases in which a PU was documented on admission, 42 improved, 27 stayed the same, and 7 deteriorated during care. A head-to-toe assessment was the most common documented evidence-based intervention for pressure ulcers. As a result, more documented interventions provided dramatically reduced their likelihood of pressure ulcer development. So as we can tell, it's very important to intervene and assess skin integrity before we move forward along with the head-to-toe assessment and if we can see a likelihood of pressure ulcer development. In conclusion, proportion of visits made by a registered nurse totaled the number of nursing interventions consistent with best practice guidelines, and higher proportion of visits made by the nurse were positively associated with improvement in client pressure ulcer outcomes. In study number 4, researchers in this study used a qualitative design using a sample of 30 nurses from 2 hospitals in addition to a community care setting. According to Athlin, Inval, Jerfalt, and Johansson, they describe factors that contribute to the progression or regression of pressure ulcers. According to Athlin, lack of time, lack of personnel, and problems in the cooperation between professionals were all valid reasons why nurses didn't act accordingly with their knowledge, even though findings showed that nurses were knowledgeable in treating and preventing pressure ulcers. In addition, results showed that based on their higher education, nurses consider themselves to have authoritative responsibility and had the attitude that is the licensed practical nurse to be concerned with pressure ulcer prevention care. New knowledge was added to the study because factors affect the trajectory of care for pressure ulcers that wasn't mentioned before in previous studies. It is recommended by these researchers that more studies need to be performed to understand factors related to pressure ulcers, treatment, and prevention.
Study 5 pertains to new nurses graduating from nursing schools. We have nurses graduating all the time. And many of them will transition into hospital settings, nursing home settings, critical care settings. So this study focused on knowledge of what the attitudes about pressure ulcer or injury prevention would be coming out of nursing school, based upon the fact that nursing school students, most of them only have clinical experience with pressure ulcers. So it was a qualitative study, and the participants were 16 volunteers from a nursing school, just one nursing school, and they were volunteer nursing students with at least 2 years of clinical. And the study was basically just one-on-one interviews with open-ended questions. The study had a lot of weaknesses. One of them was the fact that there was no diversity. All the students came from the same background. They were at the same school. They were at the same clinical, so they had very little knowledge of, to form an opinion of the pressure ulcer prevention and programs, etc. The participants were interviewed. They were not observed, and they had expressed, it was thought that they had expressed a commitment to pressure ulcer prevention in order to please or impress the primary investigators. So the result of the survey was that there was a higher interest in PIP, but really, they didn't really think that that was kind of accurate because of the impression that they felt the students wanted to make. Study 6 is about pressure ulcer prevention program, and it's a mixed method study. It was aimed to determine the effectiveness of PUPP in reducing the prevalence of pressure ulcers. The participants were nurses, allied health professionals, and healthcare aides. Data collection consisted of one-on-one interviews, participant observation, and repeated observational surveys. This was actually one of the articles that I really enjoyed reading. It's similar to other studies that we did in here, however, it does focus on prevention. And based on the 6 analysis, there's strong and convincing evidence that proper implementation of known pressure ulcer prevention measures established greatly reduces the risk of pressure ulcer formation. Even though hospitals provide education and effective workshops, it's ultimately the healthcare provider, the nurse's responsibility, caregiver's responsibility to follow through with correct implementation of relating to prevention and treatment of pressure ulcers. So it's like leading the horse to water. You have to get them to drink. We can put these people in workshops and teach them, but they have to go forward and utilize the information. Patient cooperation and compliance is important too, because you can also have a patient that doesn't want to go with the program, and that will obviously affect their care. So patient cooperation and compliance is a huge factor for positive pressure ulcer prevention and treatment outcomes.
For our discussion, we talked about prevention. Prevention has to be the focus in all aspects of pressure ulcers. We want to prevent bed sores. We want to make sure that we are constantly assessing our patients with their skin integrity. We're turning them every few hours. We're assessing their pain, assessing their wounds. Intervention is important as well as the PUPP. Intervention should be extended to all patients. Patients need to be a part of the process. It can't be a one-way street where the nurse is only teaching and guiding and intervening. The patient also needs to learn about the intervention and compliance. Intervention begins at admission or onset illness, and patient cooperation is needed. Like I said earlier, Nicole and I have been talking about what we would lead as a discussion as future RNs and what we would teach our patients, and it's important to provide patient education and teach back. There's a lot of talk about how a lot of patients are returning back to hospitals because maybe care wasn't great enough, but we have a lot of returning visits, and we need to branch out of that. And as new and future nurses, we want to make sure that our patients are receiving the education and using evidence-based practice, they're compliant, the teach back, and we wouldn't want to see a patient again. We want to make sure that they can take care of themselves.
Yes, and plus it's also very costly for the hospitals. Patients are coming back, and hospitals are paying for it because the health insurance companies, and especially Medicare, they are not reimbursing these hospitals for patients that are coming back. I mean, not all pressure ulcers are developed in the hospital. A lot of them are developed at home under the care of family, friends, caregivers at home, home health aides. Those pressure ulcers are obviously paid for if the patient has one upon admission, but one that's developed while in the hospital, it's not going to get paid for. So educating everybody on pressure ulcer prevention is what we have got out of these studies that we have read, and
as well as treatment and
development of new forms of prevention. So that's our presentation. We thank you for watching. Here's our references, and
have a nice holiday.
Yeah.
Bye.